Well, I can remember back to when I was a resident, and we would typically admit a patient for colorectal surgery, usually 2 days before the surgery, would put them on a 2-day bowel prep. If they didn't have their surgery, they would routinely have a nasogastric tube after surgery. And the most difficult decision that only the chief resident could make would be when to pull the nasogastric tube, which often wouldn't come out to the 4th or 5th day after the patient had had a bowel movement before we began advancing their diet. With this pathway, we rarely, if ever, use nasogastric tubes. Bowel preps, if they're used at all, are clearly done on an outpatient basis, and by kind of optimizing the perioperative care of the patient, we start early feeding with the idea that they may be discharged as early as the second or third postoperative day.
Preoperative counseling is a big portion, letting the patients know what to expect, if there's bowel preps or not, increasing their nutrition beforehand. Intraoperatively, we try to decrease time in the operating room, decrease the incision, doing laparoscopic surgeries when possible, and fluid management, decreasing the amount of IV fluids they get. And then postoperatively, early feedings, early mobilization, with the expectation of them going home within a few days after surgery. We
kind of modeled our enhanced recovery pathway after the Mayo Clinic's approach and made it a multidisciplinary approach to kind of developing the pathway to begin with. We included stomal therapy, we included our preoperative nurses, we included anesthesia, as well as involvement of the nurses in the recovery room and on the floor. We involved dietary. All our patients are evaluated and followed by a dietitian in an early postoperative period. And again, if necessary, stomal therapy continues to monitor the patients in their postoperative care. There's also a very vigorous patient education approach that we prepare the patient preoperatively with a fairly comprehensive folder that kind of outlines their expectations in terms of what to expect in terms of the perioperative care and what they can expect after surgery.
From the PACU staff to the nurses on the floor, they've really noticed a difference, and the patients, with their expectations of being in the hospital a couple days, ambulating immediately after surgery and taking a diet early, have been very good. And I've seen some of the patients go home in post-op day 2, post-op day 3 after major bowel resections.